Ciao mondo, hello world, hola mundo, hello monde. We're here today with an old friend, Paul Palevsky, at the Vicenza International Course on Critical Care Nephrology, and Paul from the University of Pittsburgh and the Veteran Administration Hospital in that fantastic city is author of a very important trial. This study will be, in this case, commented directly by the author, and I would like to invite you to present it to our attendees.
So the PRESERVE trial was a randomized trial of patients undergoing coronary and non-coronary angiography with the goal of preventing long-term complications in terms of kidney function. We enrolled just under 5,200 patients. And the two interventions in the trial were either saline compared to bicarbonate or N-acetylcysteine as compared to placebo for prevention as the primary endpoint, composite endpoint of death, need for dialysis, or persistent decline in kidney function at 90 days. And we also looked at acute kidney injury at 3 to 5 days after contrast exposure. What we found was that bicarbonate was no better than saline, and that N-acetylcysteine was ineffective at either preventing the primary endpoint at 90 days or at preventing AKI at 3 to 5 days after contrast exposure. So our feeling is that after years of small studies looking at these interventions, that we now have a definitive study that shows that bicarbonate is not better than saline and that N-acetylcysteine is nothing more than a smelly placebo.
Were those patients receiving either saline or bicarbonate also recruited for acetylcysteine or nothing in the 2x2 factorial?
So it was a 2x2 factorial design. So there were, patients fell into 4 groups. So we had saline plus placebo, saline plus NAC, bicarb plus placebo, or bicarb plus NAC. But there was no interaction between bicarbonate or N-acetylcysteine, so we could analyze based on the individual interventions. But patients did receive the combinations.
In the past, using bioimpedance, we were able to show that you can achieve benefit from hydration only in those patients in which you effectively obtain a true fluid hydration. If the patient comes dehydrated and you simply replace some fluid, you may have no benefit. Did you account for this?
So we did measure the left ventricular end diastolic pressure as an objective assessment of volume expansion, and the median LVEDP was just under 18. So the patients were well volume expanded.
I have a personal question, which is something that may come to the mind of every people that listen to this Cappuccino. If you have to do an angiography, hopefully not, but if you have to do it, would you take some acetylcysteine?
No.
So you are coherent with your results?
I am convinced of the results.
I am partially convinced in the sense that if the effect of acetylcysteine may be an antioxidant effect, for example, in the small amount of people who have high reactive oxygen species may have an effect. So your trial described the general absence of effect in the overall population and in the population recruited in your study. However, it does not prevent us to consider the possibility that in single conditions, this measure may have an effect. What do you think?
There's all, randomized trials always are looking at a response across a broad population, and within the population there may be subgroups that have a better response than others. Or differential response than others. from the analyses we've done thus far, and we're still working our way through multiple secondary analyses, we've not seen identifiable subgroups that we can say, yes, in this population, N-acetylcysteine or bicarbonate would be beneficial.
What was the quantity of contrast more or less reproducible, or did you normalize for this? Or?
So the average volume of contrast given was 85 ml, which was actually a bit smaller than we had anticipated. We've looked at the subgroup of patients who received more than 125 ml of contrast, and there was no benefit in that subgroup in the pre-specified subgroup analyses. We've looked at the data as well. The VA has a very large database of all patients undergoing cardiac cath, and there does appear that over time the volume of contrast given for procedures has progressively decreased as the cardiologists have become more facile, as they've moved to biplanar imaging techniques. So I think that this clearly represents the care as it's delivered in 2018.
But did you find any difference in patients who received higher dose of contrast?
No, there wasn't a.
Because
there was no difference in the effect at the higher versus lower contrast volume in the patients who received PCI versus just diagnostic procedures. The results appeared to be very consistent. In the pre-specified subgroups that we looked at, the only group where there seemed to be a difference were in the patients who underwent non-coronary angiography, where we actually saw a better outcome with saline than with bicarb, although we're very skeptical that that's a result that holds up, because it was a relatively small subset of patients, and after adjusting for multiple comparisons, the p-value is no longer statistically significant.
So you adjusted for different risk factors?
Yes.
And two more quick questions. Isn't that nice to have the author of the study here and being able to comment on this rather than reading the paper? So did you use low osmolar contrast media or isoosmolar?
So everyone received either low osmolar or isoosmolar agents. 56% of the patients, I think it was the percentage, so slightly over half of the patients received iodixonol, which is the isoosmolar agent. The remainder received various low osmolar agents. We discouraged the use of iohexol because there are some data that suggest that iohexol may have a higher risk profile than other of the so-called low osmolar agents. And we did not see any difference when we looked at the subgroups of low osmolar versus isoosmolar.
Overall, last question, what was the average incidence of contrast-induced AKI that you observed?
So it was about 9% in the overall, so that's the outcome at 3 to 5 days, which was our secondary outcome. So about 9% of the patients developed AKI.
Fantastic. Thank you so much for joining today, Cappuccino from Vicenza, and have a wonderful, wonderful day. Excellent.
Delicious.